Okay, so this is my agenda for possibly the next 30 minutes, and though it looks a tad ambitious, I promise I will be on time. Okay. I'll take you back in time a little bit to when I was a little girl, and my mom raised me with certain values, and she told me that money is only secondary to other things in life, and there are a whole bunch of things that money can't buy. And God bless my mom, she still lives by these rules, and I mean no disrespect when I say I can bring each and every one of those down one by one. Money can buy you just about everything on that list. But today is about health. Now, it may seem a bit intuitive that when you have money, you have the resources to live a better life. But the truth is, over the past couple of decades, there have been several hundred studies that have documented the correlation between income and health. And I don't want to spend time talking about all of those, but I will bring to you 2 Canadian studies just to really hone in on the topic. In this study, the researchers took a cohort of the Canadian population and they divided them into 5 groups. The top group, or the quintile 1, comprised of the 20% of the population that earned the most income. Q5, or the bottom quintile, comprised 20% of the population that earned the least income, and therefore they graded the population into 5 groups based on their income. What did they do next? They followed the cohort over 16 years and compared the number of deaths in the top group. I'm going to try and find the pointer here. Yeah, in the top group, and compared it to the bottom 4. What did they find? If everyone in the bottom 4 groups was earning the same as everyone in the top group, there would be 40,000 fewer deaths across Canada every year. And I'm going to say that again. If everybody in the bottom 4 groups earned the same as the ones in the top group, there would be 40,000 fewer deaths every year in Canada. My friends, that's 110 deaths a day across Canada. Now, if 110 Canadian deaths a day isn't a newsflash, I have no idea what is. I'm not a statistician. I have no intentions of making everyone statisticians in the next 3 minutes, but there are a couple of things that this study brings to light. First and foremost, if we look at the top 3 lines and compare them to the bottom 3 lines, women outlive men no matter where they are. Okay. What else do we see? That over the past several decades, life expectancy in Canada has gone up. Take a look at the point around 1986. The Canada Health Act was introduced in 1984. That meant that economic barriers to accessing health were no longer relevant. So we have an improving life expectancy, and now I want you to make one observation. If we compare the income quintile groups, so let's look at the men, the richest income quintile group and the lowest, there is a persistent gap amongst the groups. And you look at this over the past several decades, that hasn't changed. If you're poor, you're going to die. If you're not, you're going to live better. So that's life expectancy. How about infant mortality? That's another very valid indicator of population health, looking at the number of children below the age of 1 who die per 1,000 population of live birth. And again, what do we see? Oh, how do I go back? Yeah, okay, perfect, thank you. So what do we see? Infant mortality has indeed improved for everybody, but the gap is still there. How robust are these findings? Let's look at ischemic heart disease. Again, fewer people are dying of ischemic heart disease, but the gap sits right there. How about cancer? This is lung cancer, where mortality has been increasing over the past several decades. The gap, it's still there. Now I ask you, why is this problematic? It's problematic for a couple of reasons. For starters, when you divide the population into different income groups, depending on where you sit on that ladder of income, the more likely you are to die or live. Why is that even more problematic? Because if we look at the statistics from 1980, the top 1% of Canadian earners earned 9 times as much as the average Canadian. In 2010, this number had gone up to 15. The way money is distributed in our society is only getting worse. The rich are getting richer, and they're few and far between. The rest of us aren't doing so well. Let's look at some of the data from the 2016 census. 14.2% of the Canadian population is living with low income. 17.2% of those are below the age of 18. A quarter of them are children. 1 in 10 of them are couch surfers, meaning they're the hidden homeless. They move from one home to another without any permanency in housing status. 8.2% of the Canadian population lives with food insecurity. What I've spoken to you right now about income, housing insecurity, food insecurity, childhood development, these are just some of the 14 indicators of the Canadian social determinants of health. So I bring you to this. What determines the health of a population? Is it our access to health care? Most certainly, yes. But that's only about a quarter of what determines health outcomes. The rest is your life and the determinants of health. So what are these, the social determinants of health? They're the quality and distribution of resources that society makes available to its members so that they can live a full life. And how exactly do they influence health? Well, for starters, 1, they influence the material resources, such as having access to shelter, food, a reasonable job. Secondly, they influence health through affecting psychological stress, chronic feelings of depression, deprivation, marginalization. They lead to an activation of the stress response, and that damages the body biologically. Social determinants also limit the ability of people to make choices in life, the ability to participate in healthy behaviors, such as going for a jog in the neighborhood, or being able to buy the 5 to 7 servings of fresh fruits and vegetables. Well, the social determinants of health are what determines those. So now I'm going to bring you to a topic that's very close to my heart. And it's close to me because I started off my career as a cancer surgeon. And as I interacted with patients, I was increasingly frustrated with the lack of clinical practice guidelines and protocols to accommodate the social circumstances of my patients. I went on to work as a health strategist and in health management, and now this is my area of academic research. So I will share with you some of my work on the cancer journey and how one's position on a social ladder of privilege influences their ability to interact with the health system. And to do this, I'm going to tell you stories of 4 women. And although the stories are fictitious, neither the images nor the names reflect real women, but I can tell you that these stories are not far from the truth. So let's talk about Nina. Nina is 37 years old. She immigrated to Canada recently. She trained as an engineer back home. Once she came to Canada, she realized that her qualifications and experience were not recognized. She pushed her way through bridging programs, even though she has 2 young children. Now she's really happy because she has a contract job with a local builder. She works long hours, sometimes does the night shift. She no longer has time to spend with her children. She has no social support system in Canada. She spends a lot of the income she earns on childcare. Her children's grades are suffering. She doesn't have time to spend with them. Her neighborhood is so-so because she has to manage her income. She doesn't feel comfortable taking the children to the local park. The local grocer has a very limited supply of fresh fruits and vegetables. She dreams of the day when her temporary contract job will lead to a more permanent position, and she can move to a better neighborhood where she can go for a walk and have access to better nutritious ingredients. Little does Nina know that her inability to access fresh fruits and vegetables, lack of exercise, chronic stress, and indeed night shift work increase her risk for cancer. She treads on with life. How about Maria? She's 62 years old. She moved to Canada 8 years ago to be reunited with her family. Maria works a precarious job at a local factory. She gets paid for the hours and minutes that she works, no more, no less. She has no health benefits, no workplace benefits. 5 years ago, Maria started to put on weight, and she's had uncontrolled diabetes for the past 2 years. Visits with her health provider are very stressful. It's very hard for her to take time off work. And when she does go to the doctor, she feels judged because her diabetes just isn't controlled. And the fact that she doesn't speak fluent English really doesn't help the situation. Maria is now at home. She pulls open her kitchen drawer, and she pulls out a request for a breast screening mammography. And she stares at the request, and she thinks, I wonder if they're open over the weekend. That way my niece can drive me and I don't need to take time off work or spend the money for transportation. She then scratches her head and she thinks, you know what if they find something? I've recently started to smoke. I need to smoke. That's the only thing I can control in my life. What if my obesity, me being fat has led to this cancer? You know what, this is just too overwhelming. And she folds the piece of paper and puts it back in the kitchen drawer, checks the time, and quickly runs off to work because she doesn't want to lose her paycheck. This is Sarah, a 48-year-old breast cancer survivor with 4 children. When she was diagnosed, she was working as an administrative assistant. She had a good job, a very comfortable working environment, and she had health and workplace benefits. As Sarah went along her cancer journey, she started to get increasingly tired and fatigued. And at around the 2-year point, she was feeling stressed, juggling so many priorities, and she was at a point of burnout with depression. Her partner told her, why don't you take some time off work? You should do this to take care of yourself. And so she did. Sarah is now 5 years into her breast cancer diagnosis. She no longer has her health care plan. Paying for her medications over the past 3 years since she quit her job has been very difficult. Out-of-month pocket expenses for breast cancer patients averages $600 a month in Ontario. She's feeling the pinch of this on her budget. She's at home. She balances the books at home. What she started to do is skip some of her medications. She knows if she skips a couple of medicines, the box can last longer. She needs to juggle the money between the children's needs and the priorities of the family versus her own medications. Skipping medications, she's aware of the fact, can increase her risk of relapse. What can she do? She tries to find work again. It's not so easy anymore to get back into the job market. And last but certainly not least, I'd like to introduce you to Lucy. Lucy is 82 years old. She's been diagnosed with metastatic breast cancer and has been told that this is the end-of-life care situation for her. She's been handed over a bunch of leaflets and pamphlets, and she's met with a nurse practitioner with her family, and they've had discussions about choices. Lucy was the caregiver for her husband when he was on his deathbed, and it's now her turn. She has 3 children, 8 grandchildren. Once Lucy returns home, one of her daughters transitions her job from full-time to part-time. This daughter is also taking care of her physically. Lucy's needs are becoming increasingly more difficult to manage. Lucy's daughter is becoming increasingly frustrated, though she loves her mom very much. She's feeling a financial pinch. She's feeling a caregiver pinch. What happens to Lucy is that she's in and out of the hospital. The days where she's in the hospital, she thinks to herself, these are my choices. These are my choices. This is how one's position on a social ladder of prestige, privilege, and income influences how people interact with the healthcare system. And we really need to balance what is health care versus what is social care, because you really can't get one without the other. They're both so intricately wound up within each other like a weave. And to think that we can just focus on health without a focus on social care and social spending would be very naive. I really like the idea of value-based medicine. I love the focus it gives to patients and on patient-oriented outcomes. And I think that truly holds a certain ability to drive change. I would like to point out one or two things, though, as I conclude my talk. This is a pie chart of something that we saw earlier, where healthcare constitutes around a quarter of the pie of what makes us healthy or sick, and life constitutes at least half, life meaning the social determinants of health. And when we place value-based healthcare in this equation, we really need to think, what are we trying to get at? Are we trying to achieve patient health and outcomes over their life course? Are we just really looking at one period of illness? And are we really isolating that from their social situation? Because if we're trying to drive value through a quarter of the pie, I'm not a mathematical genius, but we're not going to get health outcomes that way. What we would need to focus at, if we're looking at the health of populations, is health outcomes that matter to citizens and costs throughout the citizen's life. Why is healthcare working in a silo? And how can we possibly even consider splitting the budget of health and social expenditure, where they're so intricately interwoven? The inputs, the outputs, everything is so similar. And I know this picture is really drastic, but I wanted to wake you up. It's not exactly like this, but if we don't invest in the social safety net, our tree of healthcare is really very dry. If our roots are strong, if the social spending, the social security of our citizens is very well-rounded and comprehensive, the fruits of the tree of healthcare are going to be fantastic. And this brings me to the last bit of my talk, which is really looking ahead with value-based healthcare. And I did a little bit of reading to see how the social determinants of health are being used to drive value-based healthcare. And what I found was that there are many databases which are now starting to collect information on social conditions for their patients. Things like, what is their income level, what is their education level, where are they housed, what is their postal code. And for me, I have a couple of concerns as we take value-based healthcare forward. One is the role of the family physician. And I know, Leah, you brought up this topic earlier with Scott. And I kind of tend to disagree, because if we're now using EMR records and matching it with a social database and putting the physician as a gatekeeper in that role, and I'm saying this as a physician, having been there, lived there, done that, if you put a physician in that role, they are not only driving administrative access to the healthcare system, they are now driving administrative access to the social welfare system. So you are now asking a physician to say, well, this patient, for his outcomes, he needs a house. This patient, for his outcomes, you need to tell him the address of a food bank. So now you need to take care and make sure that you have referred this patient for relevant social services, or else you are not going to get the health outcomes you're looking for. My other concern is that physicians, although many of us are absolutely so noble and we would never do such a disgusting thing as cherry picking, but we do. We want the patients who are easier to manage. They cause us less stress. Our outcomes look amazing. And we do financially very well. The last thing we want to do is put physicians in the unethical position of cherry picking. The lifestyle drift. What is the lifestyle drift? If we will be using these social indicators to improve health outcomes by basically driving access to social resources. And I'm not saying that's not important. I think access to homeless shelters, access to food banks, and access to other social services, employment services are very important, but they are a Band-Aid. They provide temporary relief. The question you all really need to ask, and I'd be so happy if everybody goes away with just this one point from my talk, is in this situation, are we just applying a Band-Aid, or are we questioning why there are so many vulnerable people in the first place? Are we even questioning what made these people vulnerable and marginalized? Which social policy is it of ours that means people can't get jobs, means people can't get their medications, means people can't take time off work? Oh, it's great, let's refer them to a food bank, but that's a Band-Aid. So when you see that Band-Aid being applied, I tell all of you, sound the alarm. That's important, but that's not where it ends. And we talk about patients and patient groups and patient values and getting the outcomes that matter to patients. The last thing we want to do is those patients that are already isolated from the healthcare system, that have difficulty accessing the healthcare system because of their language, because of their marginalization, because they lack trust in the healthcare system. When we drive patient outcomes based on only those patients who are available and accessible and continue to ignore those that don't engage with our health system anyway, we're doing a mass injustice to those people. And my last point, when we invest in the healthcare system, which is very important, we need to consider the social safety net as well. If the size of our sieve is so big and the mesh net is so wide, everything that we put into the healthcare system is going to go straight through, and we're not going to end up with the population health outcomes that we set out to achieve. So this was my talk. Thank you so much for listening.
We've got some questions. Where are the mics? There's one up front here. Anybody else have a question at this point? And one all the way in the back corner. Okay, let's go, Louise.
Thank you very much. This is my first question of the day, which I'm sure everybody is shocked that I've been able to hold back this long. I don't know if you've read it, but I always come with new books for people. Mm-hmm. So the one that I'm engrossed in at the moment, although I stay away from sharp objects as I read it, is 21 Recommendations for the 21st Century by Yuval Harari. You reading that too? Oh, you're always competing with me. Like, what is that? So he says two things in it that really resonate with your talk, and I think they're really going to be important to us in the next day and a half. One is that in the future, he/she, mostly he, who holds the data holds the wealth and health, and that data is going to be the new currency for health. You may have a comment about that. I want the room to remember it because we're going to be talking a lot about data going forward and who owns it, what we're collecting and who owns it. So it's just a little, hold that thought. The other thing that he says that's could be very depressing is that jobs are going to go away and they're not going to be replaced by other jobs. They're going to be replaced by artificial intelligence and other ways of doing things, and that some people, many more people, are going to basically not have a job in their life. I mean, I hope he's wrong, but I fear he's right. And he's talking about a solution to that as sort of minimum, not income, because income we think of, I guess, as out of jobs, but a minimum amount of money that people should be insured in the society in order to be able to function. And he talks about two ways of doing that. One is actually giving them the money, and the other is making things free. Free education, free health, and he clearly supports the second over the first. I'm wondering if you'd like to comment about either or both of those thoughts.
Sure, absolutely. I do think data is increasingly very important. It is like a conversation I was having with my peers on the table back there. It's what you do with the data. And what we could do, as what I've read recently is happening with the social determinants of health data, is we're increasingly using it to kind of flag the patients that are socially vulnerable. And there's some nice research that was done by some professors in Alberta, and I forget the names, and I can definitely share it with those of you who are interested. And they kind of put the point out there that what if you flip the data question, right? So instead of using that data to point at individuals and say, well, this is your problem, this is your problem, this is your problem, here's your prescription, here's what you should do, because that leads to stigmatization and further mistrust with the system. How about we flip that data question and you take it back to the policymakers and say, well, you know, in this geographical area, 30% of the population faces a housing crisis, and only 50% of the population has access to fresh fruits and vegetables 2 times a week. So policymakers, what are you doing about this? So you really need to flip the data question and take it away from an onus on individuals and use that to map policy issues and raise policy questions. That's where the politicians come in. That's where patients can play a profound role. And the second question, I get so passionate when I answer questions, I forget the second question. Jobs, yes, lack of jobs. Well, again, that's a policy issue, isn't it? And we need to consider how income is being distributed and redistributed right now. It's not that there are no jobs. There are some jobs, and there are some people that own everything. Probably Google and Amazon, right? Just to name a few, but they are increasingly owning more and more and more of what exists. So who speaks up to that? And I know we can say, well, what can we do as one single individual? And I kind of like to say, and use the analogy of recycling there and say, well, if we all decided not to recycle, that'd be a big problem, but we all do our own little bit. So play a role as a citizen. When it comes time to vote, when it comes time to speak up about a certain issue, just sound the alarm. Say, you know what, this isn't correct. Why does our taxation policy allow for this to happen? How do we allow an enterprise like that to give precarious jobs? We need to call it out. Once we have the numbers, we can raise our voice enough to create change.
Thank you. I've got one question in the back and a couple in the middle here. Okay, great.
Hi, my name's Kimberly Robinson. I'm a pharmaceutical market access and pricing consultant and a caregiver. My spouse has had Parkinson's for the last 7 years. First of all, I want to thank you so much for this topic and the passion you brought to it, because I was sitting here thinking this notion of choice in healthcare accrues only to people with significant resources, including a lot of money. And even if you have that money, when you get sick, when you become a patient, it doesn't last long because there's just a lot of burden on you. I'm in a situation now where it's not even about what the resources you have, it's about where you live. I'm living in a 2-bedroom apartment with my husband, housing my cousins who live in northwestern Ontario, who had no choice to have care close to home. Luckily, they have relatives in Toronto, but they had to come to Toronto with a 2-year-old child. They didn't fit into any of the boxes of the subsidized housing. They were left with the notion of staying in a hotel. They don't have the money for that. I mean, we have so many problems around income support for people who become ill, and really it's a secondary thought. And if you talk about what patients prefer, they prefer not to have financial stress, and we really, really need to think about that in this context. Thank you.
Thank you. I absolutely agree with all of those, and it's exactly how the system is structured, where we assume just access to health care or the point of entry to a healthcare system to exit, so you enter alive with a condition and then you exit dead, is going to be your measure of outcome. But actually, it's everything underneath that that enables your access to healthcare. And it's precisely there where patients are falling through the cracks. And that's where we need to heal from.
Thank you. Okay.
Yes, hi. Thank you so much. Great presentation. My question is, can we think of a model where patient groups are actually integrated in the continuum of care of patients for each step that you were showing us, like in their trajectory of care? How can we help? Because we get the calls after to help the patients and financially, and help them with their lodging, their transportation, all of that.
I think what would be great is, as we help patients along their care trajectory, and I know in the healthcare system we have nurse navigators that help patients get through the confusing healthcare system, but from a patient level, it's just so wonderful to have patient advocates to kind of soothe the person through their journey one by one. What would be fantastic is if we could start keeping a log of the kind of issues that they have. And again, for me, it's always about speaking back to policy, because the issues are policy created and can be policy solved. We're not going around distributing a box of Band-Aids. We need to do that. We absolutely need to do that. But to create sustainable change, we need to speak back to policymakers. When you have numbers, you know what? I saw 20 patients this week, and we talked to them about the issues that matter to them. And as our friend at the back said, housing is a big issue. When they come into urban Toronto, they have no way to access those housing resources. They don't qualify for subsidized housing. They fall straight through the cracks. So bring that out. Power is in numbers.
Okay, thank you. One here and another one over there, and then Ron. Okay, we're good? Good.
Thank you again so much, Dr. Sayani, for an amazing presentation that added a lot of value to my thinking around this topic. One of the principles around value-based healthcare that we're going to be talking about more is the benefit of interdisciplinary teams. And when you talk about, 50% being related to social determinants, and you talk about doctors being that gatekeeper and just being cautious of that, it made me think that, who else needs to be part of this conversation? And I'm thinking about social workers and psychologists and occupational therapists, people who have that direct contact and are often the gatekeepers to these social programs. So I'm wondering if you have any thoughts on how we can integrate conversations with those professionals, considering, often it's very siloed in provision of these services. Any thoughts on that for us to consider?
I would say actually goes beyond that as well. So we're not just talking about interdisciplinary teams in the healthcare system. I'd say if you're on the table with a corporate employer, you need to talk to him as well. What's his work policy? If you are sitting with a school principal, have a chat with her. What does she say? How does she address these issues? What is she looking at? What are her thoughts? Again, we need to address the fact that this is a systemic structural issue. It's not a one-off. It's not one patient who lost their way, or it's not one person who couldn't find a job, or one person who's suffering low income. This is a systematic issue. So we need to speak across all boards. And the more people that are engaging in this conversation, the more people that can become responsible employers, responsible educators, responsible institutions, we can create more change. Physicians probably will remain gatekeepers. That's the way it is structured. But there are many other people along the way that can influence how resources are allocated. I hope that helped answer a little bit.
Okay. Another one over here.
Hi, I'm Jamie Mackop from the Canadian Cancer Survivor Network. Thanks again for the wonderful presentation you made on the cases to really show real-life application of how it is working in the system. And I think you kind of answered my question already, and a concern that I've had. I mean, value-based healthcare, value-based approaches to healthcare, it sounds good, but I'm having difficulty in really interpreting it and applying it to real life, because I'm seeing a contradiction between, we talk about value-based healthcare, but it sounds like it's coming from a universal formal equality approach, whereas we're experiencing with substantive equality is what I would think that we need to approach it by. And I'm not sure if you can correct me if I'm wrong, because I haven't read the book, I'm sorry. But if you can understand where I'm coming from, where we're assuming with value-based healthcare that the physician will know and will give the right information to the patient, and we're assuming that the patient knows what to do and will have the best, will come to terms with the physician, but we all know that that's not really the case. And so how can we address that universality approach that we're kind of taking with value-based healthcare and really come forward with it from a substantive equality approach?
I love your question, because I know when speakers earlier today spoke about the Martini Clinic, and it was amazing. But the first thought that bumped to my head was, okay, so who are the people that are going to travel to Martini Clinic? Who's going to be able to take that time off work and afford the transportation in the hotel? And who's going to be left behind for the hospitals that aren't so great? And we really need to keep that into consideration as well, because we have a health equity gap, and that's been going on since 1975 when we started to measure it. The last thing you want is for this gap to increase, because certain people are able to access the availability of those tools and means and services way better than others. Those that have access to money, internet, and one of the most common examples that I give is if you go to Cancer Care Ontario, they have a My Cancer IQ, so you can log in online and take their test, and they tell you your risk of cancer. And I say, well, you know, go to a deprived neighborhood and see who has access to that website and who has the time or motivation or intent to check their cancer risk. So who's screening, who's going to the provider, who's seeking the care, and who's being systematically left out. It's all about the system, and we need to make a conscious effort to really undo this way of thinking about things.
Okay, thank you. One more over here, two more over here, all right.
Two more. I'm just
Yeah,
going to
just
permit
in front of-
myself,
yeah.
if I may, to make one comment, since Louise and I just discovered that we're reading the same book, 21 Questions for the 21st Century. The author does mention the fact that there are experiments going on in several jurisdictions, including Finland, Switzerland, and Canada, where here in this province we have had a project, pilot project on guaranteed annual income, but it's been canceled.
Yeah.
So his book is now out of date, sadly. Sad to report. Just, you know, for further discussion, because one of the challenges is really relates to how we as patient and, and health system and community health advocates, what we can do potentially to working in coalition to address some of these issues, when often we're caught up just dealing with the specifics of the diseases that we represent.
I think it's unfortunate that the pilot was canceled. I do have some thoughts, however, over the basic income pilot, and it may not just be relevant to this, but in general to the whole ideology, is if you are cutting other forms of social expenditure spending, so if you're canceling a child welfare benefit and you're canceling an employment benefit and then giving them a basic income, so you're kind of balancing the books, so to speak, and not really adding anything to the pockets, then we're doing a bit of an injustice. I also think that, again, it's a great idea, but I do think it is also part of a Band-Aid approach, a much larger and comprehensive Band-Aid. But again, we do need to question why are funds distributed in our economy the way they are. I know we can't possibly do anything as one single person, but the more questions they are, the more issues we raise about why is income inequality increasing in Canada? Why is it getting so perverse, and why are we silent about it? I think that is a much larger question.
Thank you.
Just a quick comment to some of this amazing discussion, and thank you so much for just generating all of it. And I look forward to hearing what comes in the breakout groups as it relates to this. But just, it's sort of this, the concept of patient segmentation within value-based healthcare I think is really important. And not just focusing at the medical condition level when you think about patient segments, because who are all those people who have never got in to get diagnosed, right? So who don't trust the systems, or for whatever, all the various, complex reasons related to determinants of health are never even going to get there necessarily, right? So how it's not just looking at the medical conditions, but also, I know that, and we're going to hear from Rod Burns this afternoon, there are certainly models of primary health care in Ontario anyways, and other places where they are looking at patient segments in terms of people who traditionally face are marginalized and have difficulty getting into care in the first place. And how are you addressing those broader concerns? So, they're looking at how do you best serve LGBT or youth or Indigenous or racialized, et cetera. And so thinking through, that concept of patient segments beyond medical conditions, but being able to look at that even further of, okay, and as it relates to people who are racialized, what's that look like for this particular condition, their diagnosis, their prevention, et cetera, right? So it's really, really important that sociodemographic information, that's looking at income, et cetera, that's looking at ethnic background, and these types of questions are being consistently asked so that that kind of segmentation in the data and understanding and learning and improvement can happen, and that the teams can become broadened and can be connecting, so that it's not just necessarily traditional healthcare providers that are there doing the work. If you have a particular patient segment that needs much more than that, you're developing different relationships, and you're doing different models of care to be able to reach them. or for them to reach you or to want to reach you, and so that the outcomes you want to achieve are equal for everybody, but it is equity, that's going to get you there, right? So yes, everyone should be able to get those best outcomes as health outcomes if we think about value, but we need to take equitable approaches to how you're how you're thinking about your patients, how you're organizing your care, how you're reaching people who may never have, touched your doors, and how you're working with them to achieve those outcomes. Sorry if I grandstanded a bit too long there.
Thank you, everyone, and thank you, Dr. Sayani. Is there any other additional comments that you'd like to make, perhaps in response to Leah?
Sure. Yeah, I know of some of the amazing work some of my colleagues in downtown Toronto at St. Mike's are doing, and they practice as family physicians, and they write prescriptions of income. So they literally ask their patients, when did you last file a tax income? And if the patients say no, they sit there. They have someone who actually sits there with them and helps them file that, and they help place them into jobs. So there are lots of ways that people are looking at this, and I think the energy and time is right. I think there are lots of conversations happening. It's about really bringing that pool of energy into one active way to move forward and have policy debates and really raise issues to our politicians that matter. Thank you so much.